return. Pulmonary valvular stenosis, VSD, pulmonary arterial branch stenosis, persistent superior vena cava, and multiple valve products. So we should also carefully look at during ASD diagnosis. We should look at draining into the LA1. So this is very careful. Only the ASD diagnosis should not be complete. Other associated anomalies, especially what we commonly miss, is the partial anomalous venous drainage. Primum defect in the inferior endocardial portion of the atrial septum, 20% of cases associated with epicanal defect, left anterior mitral defect, and associated with Down syndrome. The ASD secondum is associated with mitral valve prolapse. ASD secondum. Here is the ASD secondum. It is associated with mitral valve prolapse, but ASD primum.
Recording in progress.
ASD primum is associated with mitral valve. Secondum is associated with mitral valve prolapse, and primum is associated with mitral valve cleft mitral leaflet. So this is very common. And associated with epicanal defect and cleft mitral leaflet. Associated with Down syndrome, 25% cases of ASD primum. Sinus venosus type ASD, only 5% ASD type, IVC type, and what we see that this is the sinus venosus type of ASD. Here is the ASD, here is the SVC, there is no HVC, so sinus venosus SVC type. Deficiency of wall that separates the right pulmonary veins from the SVC and the right atrium. So here the right pulmonary vein comes. Anomalous drainage of the right upper pulmonary vein is associated with 95% cases of SVC type of finding. So the roof is deficit. So near the roof, the right upper pulmonary vein drains. So when the roof is drained, the right upper pulmonary vein is draining into RA, not into A. So during sinus venosus type SVC type ASD, we should comment about the right upper pulmonary vein, whether it is draining into LA or not. Mainly 95% cases, it drain into RA. IVC deficiency of the wall that separate the right pulmonary veins from the IVC and right atrium. Least common type usually associated with anomalous right lower pulmonary veins. So, sinus venosus type of ASD is associated with anomalous pulmonary veins. This is the coronary sinus type of ASD. This is a rare picture. We're showing the movie clip. Are you watching the movie clip?
Yes, sir. দেখা যাচ্ছে.
This is the right atrium. This is left atrium. Right ventricle, right atrium, left ventricle, left atrium. So this tube part is this tube structure is the coronary sinus. This coronary sinus traverses draining into RA, goes through over the LA as a root, and unroofed coronary sinus is the coronary sinus type of ASD. So this is the coronary sinus. Here this wall, the lower wall of the coronary sinus is deficit. So the roof of the atrium is deficit, left atrium. So there is a communication between the right atrium and the left atrium to the coronary sinus due to deficiency of lower part of the coronary sinus wall. So this is the coronary sinus type of ASD. So this is a rarest and less than 1% of cases and associated with partial anomalous venous drainage, persistent superior vena cava, pulmonary atresia, tricuspid atresia, heterotexis syndrome. So this is a rare picture in my life. One cases I have so far diagnosed this coronary sinus type of ASD. So this is the physiology of the. This is the physiology of the normal physiology, and the physiology of ASD and shunt is determined by relative compliance of the two ventricles. And I stop to 1 minute for azan. Physiology of ASD, the shunt determined by relative compliance of two ventricles. At birth, the right ventricle is less compliant, provided systemic circulation through the ductus arterioles. After birth, lung expanded, pulmonary vascular resistance drops, systemic vascular increases over a period, LV support system systemic ventricle, LV become less compliant, RV become more compliant. So this is at birth. There is a shunt. The shunt increases after birth, and so RA and RV becomes dilated. The natural history of ASD, spontaneous closure occurs more than 80% of time in patients with defect between 3 to 8 millimeters before 1.5 years of age. If it is less than 8 millimeters, it may be closed spontaneously before 1.5 years of age. More than 8 millimeters rarely closes spontaneously. Spontaneous closure is unlikely to occur after 4 years. So this is very important, the natural history. If the defect is less than 8, if there is a chance of closure, and the closure, it may occur spontaneously within 1.5 years of age, but after 4 years of age, if ASD persists, it is rarely unlikely to occur. Most children remains active, asymptomatic, symptoms appears as age advances. So ASD patient mostly asymptomatic. For that reason, it is undetected. And I got a patient of stroke of 72 years presenting with ASD, and for the first time it was detected at the age of 74 years. So it may not be detected before adulthood. এখন কি আপনি ভালো শুনতে পাচ্ছেন না? আমার সাউন্ডটা কমানো ছিল, সরি। হ্যালো,
জি স্যার, ক্লিয়ার স্যার।
ভলিউম একদম লোতে দেওয়া আছে, সরি। সো এই ন্যাচারাল হিস্ট্রিটা কিন্তু আপনাদের জানতে হবে। 8 মিলিমিটারের নিচে হলে এটা সাধারণত ক্লোজ হয় না। 4 বছরের পরে যদি কারো এসডি পারসিস্ট থাকে তাহলে সেটা সাধারণত ক্লোজ হবে। Rarely congestive heart failure can develop in infancy. এটা খুব রেয়ার। If large defect remain untreated, congestive heart failure, pulmonary hypertension begins to develop in adults who are in the age of 20 to 30. So 20 থেকে 30 বছরে এটা symptom, it becomes common after 40 years of age. Life expectancy is not normal and is 6 years per year after the age of 60. So এটা একটা আপনাদের মধ্যে এখনো এবং আমাদের কার্ডিওলজিস্টের মধ্যে এখনো এই জিনিসটুকু আছে যে এসডি যদি বড় হলে আর ক্লোজ করা লাগে না, এই বয়সে ক্লোজ করে আর কি হবে। দেখেন, the life expectancy is not normal in unrepaired patients, with mortality increasing by 60% per year after the age of 40. So there is an increase, and this is reference from HERS. So Mosen Adams HERS. So and up to date. So this is not true that after the age of 40, the ASD closes has no benefit. Pulmonary vascular resistance usually is progressive and become irreversible. Chronic venous volume overload, elevated pulmonary arterial pressure, ventricular dysfunction, and AV valve regurgitation can contribute to the atrial stretching, which in turn predisposes to atrial arrhythmia. So this ASD is predisposes to atrial arrhythmia. Infective endocarditis does not occur in patients with isolated ASD. So infective endocarditis is not a problem. Because why? Because it is a low pressure area. So low pressure area, there is less chance of endothelial injury and infective endocarditis. Cerebrovascular accident resulting from paradoxical embolization through ASD is a rare complication. It can happen. So any venous clot may travel through ASD to the systemic circulation and producing a stroke. So hemodynamic significant ASD, regardless of symptoms, if untreated, what is the problem? So hemodynamically significant ASD, regardless of symptoms, if untreated, functional limitation, frequent atrial arrhythmia, increased pulmonary hypertension, right heart failure, more Ascendmanger syndrome, and decreased life expectancy. So this is not true. The ASD should not be closed. There is no benefit. So both mortality benefit and morbidity benefit occurs even after the age of 40, because the chance of the mortality increase 6% per year after the age of 40 if untreated. Presentation asymptomatic, incidental findings, routine follow-up, repeated chest infection in the children, dyspnea on exertion. Progressive shortness of breath, congestive heart failure rarely present, worsening of clinical condition in adult due to coronary artery disease and hypertension, cyanosis and exertion, syncope in Ascendmanger syndrome. Physical findings. Signs. The left precordial bulge, prominent right ventricular impulse, P2 may be palpable and loud if it is due to pulmonary hypertension. Wide and fixed bleeding of the second heart sound, wide and fixed splitting of the second heart sound of the with the respiratory cycle. Soft pulmonary mid-systolic flow murmur in the second and third left intercostal space. As we all know, a mid-diastolic murmur, the tricuspid regurgitation flow, may be present in the lower sternum. So precordial bulge, precordium may be bulged, especially in children. Prominent right ventricle, P2 may be loud, ejection and systolic murmur grade 3. There is no grade 4 murmur. So grade 4 murmur, ASD murmur usually should not produce any 3. And there is maybe features of pulmonary tricuspid regurgitation murmur in the lower part. Left to right side, increased pulmonary flow, endothelial dysfunction, and vascular remodeling, smooth muscle proliferation, increase in the increased PVR, inversion of shunt, right to left, cyanosis, Ascendmanger syndrome. So, what is the change in the pulmonary circulation? Endothelial dysfunction and vascular remodeling, smooth muscle cell proliferation, increased extracellular matrix, intravascular thrombosis, all produce the increased pulmonary vascular resistance, inverted the shunt right to left, and the cyanosis, Ascendmanger syndrome. Physical findings: left precordial, by pulmonary hypertension and Ascendmanger syndrome, functional impairment with pulmonary hypertension and Ascendmanger syndrome. The presentation is functional impairment, cyanosis, prominent AOF, parasternal hip, P2 palpable and loud, wide fixed bleeding of second heart sound and tricuspid murmur disappears because the Ascendmanger syndrome. Mid-systolic pulmonary flow murmur is replaced by a softer and shorter murmur, high frequency early diastolic murmur, Graham-Still murmur of the pulmonary regurgitation, and sinus venous defect develop pulmonary hypertension at an earlier age compared to the patient with other forms of ASD. So sinus venous type of defect may develop pulmonary hypertension at an earlier age. এটা নিয়ে আমাদের স্যারদের মধ্যে একটা কন্ট্রোভার্সি ডেভেলপ করছিল কোন একটা পরীক্ষা যে কারা আর্লি পালমোনারি হাইপারটেনশন ডেভেলপ করে। So it is the sinus venosus type of defect that develops the pulmonary hypertension earlier than any other form of ASD, even earlier than ostium primum defect. So it is the sinus venosus defect who develop the pulmonary hypertension. Basic investigation, pulse oximetry, ECG, X-ray, echo, cardiac MRI, and CT. The importance of pulse oximetry is very, very important, and we should have a pulse oximetry in our practice lab because it gives many information. When a patient at Lumia, the pulse oximeter showing the saturation is less than 90%. So there's every chance the patient may develop pulmonary hypertension severe and the isolated syndrome. So it is an investigation tool. So every time nowadays it is a common practice in our day-to-day life. But without that, X-ray, cardiac MRI, CT rarely required because cardiac CT required only in complex congenital heart disease. Cardiac catheterization in ASD cases, routine cases, there is no need of cardiac catheterization. Only in borderline cases where the pulmonary hypertension is moderate to severe, whether we can close the ASD defect or not, and we should. In that cases, we will only do the cardiac catheterization. The ASD secondum RSR pattern in V1, the ECG, QRS duration, incomplete bundle branch block is less than 0.001, right axis deviation, RV hypertrophy, first degree block, and RA enlargement, all are presence of ASD. The Crocket's sign, a notch near the apex of R wave in the inferior lobe, the Crocket's sign. The Crocket's sign, 73% patient with secondum type of ASD. This is the Crocket's sign, a notch in the a notch near the apex of the R wave in the inferior lobe. So this is the lead 3, this is the notch, this is the notch, this is the Crocket's sign, 73% patient of the with ASD secondum frequently. Frequency correlate with the size of the defect and degree of the left to right shunt. The more the size, the more the left to right shunt, the Crocket's sign is. So it is also a common sign, the Crocket's sign. Primum type of ASD, RSR pattern, V1, left axis deviation. The previous one is the right axis deviation in secondum type of ASD. But here in the primum type of ASD, there is a left axis deviation. First degree is the classical seen in the right bundle branch and left anterior fascicular. The chest axis. The cardiac shadow is enlarged, silhouette is enlarged. Increased vascularity suggestive of prominent pulmonary vessel. This is the prominent vessel. This is the right pulmonary vessel. This is the right pulmonary artery. This is the left one. And the diameter of the right pulmonary, if it is in case of male more than 18, it is dilated. In case of male more than 18, it is dilated. In case of female, if it is more than 16 millimeter, this diameter is 16 millimeter or more. In female, it is dilated. Visible vascularity in the peripheral lung field. The hypervascularity is the features of ASD. But in case of Eisenmenger syndrome, this vascularity, the peripheral vascularity. So hypovascular, hypervascular, normovascular. What does it mean? If we divide this lung field into 3/3, medial 1/3, middle 1/3, and lateral 1/3. So normal vascularity, what is normal vascularity? Up to middle 1/3, the vascular markings are visible. But here, even after middle third, the lateral 1/3 also contain the vascular. So it is hypervascular or plethoric lung. But what is hypovascular or pruning? What is pruning or hypovascular? If the vascular marking is limited only in the medial 1/3, not found in the middle and the lateral 1/3. So this is the hypovascular marking. So normally it is plethoric lung field, but in case of Eisenmenger syndrome and the vascular resistance is developed, vascular resistance, the pruning of vascular pulmonary arterial vessels developed. So the vascularity is not visible beyond the medial 1/3 of the lung field. So this is the and this is the bulging of the pulmonary conus, full. This is vascularity, peripheral lung field, increased vascular. This is the pulmonary bulge. This is also an indication of, and this is the medial 1/3, middle 1/3, and lateral 1. So here is the lateral 1/3 also contains the vascular one, and this is the dilated pulmonary artery. This is another dilatation of the pulmonary artery. So all we can find here in X-ray chest. Inoperable evidence. So this is the patient with ASD, but the vascularity is decreased, normal heart size, normal or reduced vascularity, evidence of pruning with the dilated of hilar pulmonary artery and rapid decline of vessels. So these vessels rapidly ends up here. The vascularity only in the medial part and few in the middle part. So this is an inoperable evidence of chest X-ray. So the vascularity is less, only medial third, and there is no vascularity in the middle and lateral one part. Anomalous pulmonary venous drainage Scimitar signs. So the ASD patient, sword, X-ray chest PFU showing a dextroposition of heart with Scimitar sign, the Turkish sword. This is the Turkish sword. Here we see the Scimitar sign. This is a Scimitar sign of pulmonary anomalous pulmonary artery, and the pulmonary anomalous venous drainage is in the IVC. So this is the anomalous pulmonary drainage Scimitar sign. X-ray chest. This is the TAPVC, total anomalous pulmonary venous drainage. X-ray showing a snowman or figure of 8. So this is the snowman or figure of 8. Echo modalities: transthoracic, transesophageal, and intracardiac. ASD echocardiogram size, number, flow, direction, rim assessment, right ventricular anatomy and function, pulmonary pressure, and associated. So this part will search in ASD patient. T, defect size, morphology, and transesophageal echo. There is a special attention, adequacy of rim before device closure, pulmonary venous connection, left atrial appendage thrombus, sizing by balloon diameter, flotation. Most in our country we do not do the balloon flotation sizing of the ASD during device closure, but in many countries a balloon is placed across the ASD during device closure, and the diameter of the wedge of the balloon is the size of the ASD. And when the transthoracic echo or transesophageal echo done during inflation, and when there is no flow across the ASD, it is the balloon size, highest balloon size, and at that point the balloon diameter is better. So balloon sizing of balloon diameter T may be also helpful. This is the ASD margins. So this is the atrial septal defect. This is the superior vena cava. This is the inferior vena cava. This is the mitral valve. This is the aortic valve. So mitral valve is anterior and inferior. Aortic valve is anterior and superior. And the posterior margin is here is the pulmonary vein margin. Here pulmonary vein opens and IVC margin. So there is different margin and terminology may be different. The SVC rim may be termed as superior rim. In IVC rim may be termed as inferior rim. Posterior rim may be pulmonary vein margin. Posterior rim may also sometimes divided into posterior superior and posterior inferior rim. And the mitral rim or our anterior inferior rim or mitral rim or heavy valve margin, the anterior superior or retroaortic rim or aortic rim, anterior superior or retroaortic rim or aortic rim. These are the name of the margins of the ASD. So during our ASD echocardiography, we will sort every margins in our 2D in our transthoracic and transesophageal. This is the views: parasternal, apical, and subgipoid. So this is the ASD secondum. Here is the posterior. Here is the apical 4-chamber view. The apical 4-chamber view. Here is our probe. So posterior mitral rim and posterior superior rim. Mitral rim and posterior superior rim. Parasternal 4-chamber view. in the apex, or transducer in the apex. So this is the plane of the echo beam, and this is the cut section of the valve. So this is the mitral rim. Here is the mitral rim, and this is the posterior superior. So apical four-chamber view, we find two rims of the ASD. This is the mitral rim. This is the posterior superior. This is the apical parasternal short axis view at the level of the great vessels. Here is the aorta. Here is the pulmonary artery, and we get this is the echo. Here is our echo. Here is our transducer position. This is the transducer position. Parasternal short axis view. This is the echo beam cut section. So this is the aortic rim. Anything problem? Any problem? Any problem?
No, sir.
So in the parasternal short axis view at the level of the great vessel, this is our transducer position at the level of the second intercostal space, and this is the echo beam cut section. So the cut section goes through aorta. There is the aorta, then it is the aortic rim, but retroaortic rim, then it is the posterior inferior rim. So this is the retroaortic rim. Represented here is the retroaortic rim, and this is the posterior inferior rim. This is the posterior inferior rim. So four rims already we have determined. So what is the four view? In the apical four-chamber view, the mitral rim and the posterior superior rim. In the apical parasternal short axis view, aortic rim and posterior inferior rim. And this is the echocardiograph. This is the aorta. This rim is the aortic rim. This rim is the posterior inferior rim. So this is the ASD. So this is the parasternal short axis view where we getting these two rims. Here is another. The aortic rim is almost absent. The posterior inferior rim is adequate. And ASD sinus venous subgyphoid bicaval. Subgyphoid bicaval view is difficult in adult patient, but if we try this, we can get the parasternal subgyphoid. If we position our transducer at 6 o'clock position or 12 position, then we give the subgyphoid. Here is our position of the transducer, and here is the plane. The upper part is SVC. This is the SVC, and this is the IVC. When it is entered into the liver, it is IVC. So this is the RA. This is the LA. This is the ASD defect. Here is the AVC is adequate. The SVC is a bit deficit. So this is very difficult in adult. Further treatment for assessment of ASD in adult usually needs transesophageal echocardiogram. The views ASD margin in transthoracic. So all already mentioned. We have parasternal short axis view and retroaortic rim and pulmonary. We have already discussed this. So views of assessment. In transesophageal echo, we are going through the ischias and we view the atria heart from behind. These are the different views: 0 degree, 45 degree, 90 degree, and 120 degree. So 0 degree, 45 degree, 90 degree, and 120. So this is the T degree, 0 degree, and the 0 degree we will get the four-chamber view in the apical four-chamber line. And 90 degree and 45 and 120 degree. We'll go one by one. This is the 0 degree. This is RA. This is RB. This is LA. This is LB. So apical four-chamber line, our home view of transesophageal echo is 0 degree. So what we get in our transthoracic echo? What are the rims in transthoracic echo in apical four-chamber view? Can anybody mention what are the name of the rims? Anybody?
Sir.
একটা হচ্ছে mitral rim sir, mitral rim আর posterior superior rim.
So this is the fourth chamber. This is the mitral rim, and this is the posterior superior rim, and this is the anterior margin of the left side and posterior margin on the right side. So this is the in apical four-chamber view. That's the transesophageal echo 0 degree view. We have two echocardiographic rims. That's the mitral and posterior superior. So this is our 4-chamber view. This is RA, this is RB, and here is the mitral valve and tricuspid valve. So this is the mitral rim, and ASD is small. Sometimes it's visible, sometimes not. And this rim is the posterior superior. Clear? If we stop here, if we step here, this is the mitral, this is the posterior superior rim, this is the atrium. Okay?
এই রোগীর কি ভিএসডি আছে স্যার? একটা মানে সেপ্টামের মধ্যে একটা গ্যাপ দেখা যাচ্ছে।
এগুলা কমেন্টস তখনই করবেন। এখানে primum membranous part of the septum is thin, so sometimes it may seem that there is no flow. So transesophageal 0 degree is here. This is a large ASD. In 45 degree, what we see in 45 degree, it is processed like parasternal short axis view through the ASD, through the aorta and the interarterial septum. So in the parasternal short axis view, this is the aorta. In the 45 degree TE view, it is short axis view in the transthoracic view. What are the name in the short axis?
Aortic rim and posterior rim.
Inferior rim.
So this is the aorta, this is the aortic rim and posterior inferior rim, and this is the ASD. So this is the cut of section of beam of the echocardiography in transesophageal at 45 degrees. These degrees are not fixed. It is varies from 30 to 60 degrees, not 45 degrees exact. So we can get that, and we will measure in every view where is the highest diameter. It is not that it is fixed in the 45 degree. It is fixed in the 0 degree. It is not fixed. From 0 to 180 degree, we will measure. We will see the ASD throughout the site. 0 to 180 degree, highest diameter and highest and lowest rim diameter will be measured. So highest diameter of the ASD and lowest diameter of the rim should be sought out for device closure assessment. So this is our short axis view. This is a long, and this is here. If we stop here, so this is aorta. This is aortic rim. This is posterior inferior rim. This is ASD. So this here. Excellent view of rims. Excellent views of rims. This is aorta, aortic rim, posterior inferior rim. So this is aortic rim, and this is posterior inferior rim. In the 90 to 120 degree, we get the bicable view. 90 to 120. 90 to 120 or 110. This is the bicable view. The bicable view here what we'll get the superior vena cava, inferior vena cava, superior vena cava rim, and inferior vena cava. If we go through, here is 90 degrees. So if we stop here, this is the SVC. This is the SVC. Here is the IVC. This is the SVC rim. This is the ASD. This is the thin rim of IVC rim. This is IVC rim. And if we play again, so look at the IVC rim, a bit thin, a bit floppy, but it is adequate. It is adequate. So we are going from 90 to 120, 180, all throughout the cycle. We are getting this view. The SVC rim, IVC rim, excellent IVC rim, but a bit floppy. This is the ASD, and so. So look at here the degrees. This is the angle. From 90 to 127, we are going throughout the site. We are rotating this. So this is not fixed. This is not fixed. So that if you see here in 90 degree, if you see here in 90 degree, there is only few views. But if you progress the degrees from 90 to 90, this is 107 degrees. So here is the good visualization of ASD and the rims. sometimes we miss the ASD if it is located in the superior or inferior part. RARV dilated. Here is the RARV dilated. IS seems intact, but there is no ASD seen. So sometimes we should be very careful, and there is the RV pressure and volume overload here in so sinus venosus type in transthoracic echo we may miss by conventional. So we have to search by subcostal bicameral view, or if we have suspicion that there may be an ASD we are not getting through the transthoracic echo, we should advise the transesophageal, or we will carefully search the subcostal view. So this is an example that the subcostal view in transthoracic echo we are getting this ASD. So here is the pulmonary vein, normal pulmonary venous drainage. So this is the this is the left upper pulmonary vein here. This is the left lower pulmonary vein here. This is the right lower pulmonary vein here. So three veins are easily visible in transthoracic echo in four-chamber view, apical four-chamber. So, and for getting the views, we have to, for blood flow, we have to reduce the NICVD limit from around 40 to 50 or 55. So we can get the flow here. But right lower pulmonary vein is visible, but right upper pulmonary vein is not usually visible in transthoracic echo. It is not very easy. And in the crab view, is also the modified parasternal short axis view. Here we can get all the four views. This is not easy in adult patient. This is in pediatric patient. We getting all the four pulmonary veins. This is our right up right pulmonary artery, and this is the REPV, LUPV. And so if we get at least three veins in transthoracic echo, we can assume that there is no presence of at least significant left to right anomalous pulmonary venous drainage. This is the PFO. This is the PFO flow. Sometimes we are getting the flow, sometimes we are not getting. Here is the RA, RA, and here is the PFO. So this is the slit, like this is not actually the cap. This is the slit flap. This is the interstitial part of the septum. This is another part of the septum. And this is the PFO. So if we get this type of flow, it will we will recognize that the PFO. Mitral valve prolapse. This is common in which type of ASD?
Sir,
Can you
ostium secundum.
Yes, and cleft mitral valve.
Ostium primum, sir.
Cleft mitral leaflet. This is the cleft. This is the cleft. So we can, if we get an MR jet in ASD patient, we should be careful what is the cause of MR. Cardiac CT MRI, anomalous pulmonary vein for detection, shunt magnitude amplification can be done and helpful if unable to see key neighboring structure by echocardiogram, like Scimitar syndrome. We cannot delineate that the pulmonary vein is draining into SVC, and so if we are cannot confirm by echocardiography, cardiac CT or MR is this. So this is a Scimitar syndrome patient of a 30 years guard diagnosed by me. Later on, they are operated in National Heart Foundation. This is a right upper pulmonary vein, SVC and IVC. The draining into the SVC and IVC. So this is the anomalous pulmonary, common pulmonary venous drainage channel. This is the Scimitar vein. So this is not sinus venous. This is the right upper pulmonary vein, the Scimitar vein, and the IVC. So the vein, when draining into IVC by Scimitar vein, which is Scimitar syndrome. So this is another patient of Scimitar vein. So cardiac catheterization is only diagnostic transcatheter ASD closure, pulmonary artery pressure, shunt magnitude, PV, pulmonary vascular resistance, systemic vascular location of shunt, and anomalous pulmonary vein. We can all detect by cardiac catheterization, but now it is not necessarily a routine ASD case because we can everything can be calculated by cardiac. Basic approach in cardiac catheter trajectory, oximetry, pressure study, and graphic. So these are the four basics of cardiac catheterization. So what is this? What we are doing here? Here is the catheter in the SVC. We are dropping into the RA. We are doing the oximetry, RA high, RA mid, and RA low. This is the RA low. Here, our catheter in the pulmonary artery, and then pulmonary artery here. And we are giving the pulmonary venography. The pulmonary vein, this is the pulmonary vein draining into LA, then the catheter is passing the ASD. Shunt magnitude, PVR, so step up more than 10% in one series and 5% in two series, shunt magnitude. So if there is a step up of oxygen saturation from the SVC and the RA, it is significant shunt for ASD. So we during cardiac catheterization we will try to go every vein. So this is the left lower pulmonary vein. This is the left upper pulmonary, the right upper, and this is the right lower pulmonary vein. So catheter is passing all four pulmonary veins. There is no partial anomalous pulmonary constraint. Hello. একটু মিউট হন, না হলে হচ্ছে না, কে কে কথা বলছেন। এটা Scimitar syndrome, the pulmonary vein, Scimitar's vein to IVC. So this is the Scimitar cardiac shadow of very vertical vein. So this is very important. ASD, VSD, PDA, high QP, QS ratio, failure to thrive, oxygen saturation more than 95%, only left to right shunt, present, operable, absent, catheterization. So saturation, if it is less than 95%, we should go for saturate in room air for cardiac catheterization. Catheterization PVR, if it is less than 6 UC, operable, standard and operation done. If it is gray zone 6 to 8, but new guideline there is it is changed 6 to not 6. It is less than 3, 3 to 5, more than 5. But here is in the previous guideline and International Journal of Cardiology, the recommendation is that 6 less than 6. If it is PVR less than 6, and it is operable. 6 to 8, it is the gray zone. If it is more than 8. Acute vasodilator testing should be necessary. What is vasodilator testing? In the next slide, we will vasodilator acute vasodilator response to vasodilator testing. If it is positive, operation. If it is negative, targeted PAS therapy, repeated targeted PAS therapy, that is drug therapy for pulmonary hypertension, repeat catheterization, and repeat acute vasodilator testing. If it is positive, go for surgery. If it is negative, not operable. So this is the gray zone. If it is in cardiac catheterization, if the pulmonary vascular resistance is less than 6, surgery is usually not possible. If it is more than 8, surgery is not possible, but we should go for acute vasodilator testing. If the vasodilator testing is positive, then surgery is possible, even in more than 8 or in the gray zone. But if it is negative, then targeted pulmonary arterial therapy, and then after 3 to 6 months, we will again do the cardiac catheterization. What is acute vasodilator testing? Acute vasodilator testing can be done with inhaled nitric oxide, 100% oxygen, inhalation of IV, inhaled or IV prostaglandin analog. So we can do by anything, inhaled nitric oxide, 100% oxygen, or IV prostaglandin. IV adenosine. Indication: assess operability in borderline cases of shunt anomaly, vasodilator response in idiopathic pulmonary hypertension, familial pulmonary hypertension, for prescribing calcium channel. So these are all the same. What we done with 100% oxygen, what we done by IV adenosine or adrenaline. So these are the acute vasodilator testing response, acute vasodilator testing response in idiopathic pulmonary hypertension, familial pulmonary hypertension. So indication is two. One is assessment of the operability, and another is vasodilator response in idiopathic pulmonary hypertension, familial pulmonary hypertension, and for prescribing complete heart valve. So all type of pulmonary hypertension is not necessary. If it is idiopathic or familial, for that reason we will do the vasodilator response for prescribing complete calcium channel block. Interpretation: shunt PVR less than 6 and pulmonary vascular resistance less than 6 US unit per meter square. Index: pulmonary vascular resistance index less than 6 US unit per meter square. PVR and SVR ratio less than 0.3. For IPH and familial pulmonary hypertension, decrease in. So for operability, it is already needed. PVR should be less than 6. It is the indicator of as acute vasodilator testing response. PVR I, pulmonary vascular resistance index, less than 6 US unit per meter square, and PVR SVR ratio less than 3. It is sufficient to call for surgery of surgery or any device closure for a shunt anomaly. So if after giving 100% oxygen, how we can give 100% oxygen? Anyone? Anyone? How we can give 100% oxygen? Anyone? How can we give 100% oxygen in cath lab? Nobody?
High flow nasal cannula.
Yes, excellent. So it is the high flow nasal cannula, and I have managed a high flow nasal cannula in our cath lab for this purpose. So 100% nasal oxygen. Otherwise, we will give the Venturi mask and other things. It is 90 to 95%, but not 100%. So this may be a short note: acute vasodilator testing. So sometimes it may confuse you that it may be different in idiopathic pulmonary hypertension, the acute vasodilator testing, and in shunt anomaly, the acute. This is all the same. We can do by 100% oxygen, nitric oxide, IV, prostaglandin, or adenosine. In one of my idiopathic pulmonary hypertension cases, we have used adenosine. I presented it in my pulmonary hypertension lecture. Did anyone present in that case pulmonary hypertension lecture of me? Anyone? I have not given any lecture of pulmonary hypertension in front of you.
Sir, I have, sir. I was present, sir.
On that occasion, I reproduced the cases of idiopathic pulmonary hypertension where we do the acute vasodilator testing by adenosine, not by 100%. So it is all the same. We can do by any management of ASD. Impaired functional capacity, right and left ventricular enlargement, left to right shunt, without sinus at rest during exercise, systolic PA pressure less than 50% of systemic pressure, pulmonary vascular resistance less than 1/3 of the systemic vascular resistance. So the recommendation of therapeutic device in that cases so QP/QS ratio, if it is more than 1.5:1. PA pressure is less than 50% of the systemic pressure, and pulmonary vascular resistance less than 1/3 of the systemic vascular resistance. In that cases, it is recommended, class 1 recommendation of surgery or device closure. Surgery or device closure. anything. So here there is no age limit that before 40, after 40, there is no age limit. Impaired functional capacity is measured by symptomatic, right or left RARV enlargement, right and left QPQS ratio is more than 1.5:1. When the RARV is enlarged, we assume that the QPQS ratio is more than 1.5:1. And the PA pressure is less than 50% of the systemic pressure. Pulmonary vascular resistance is less than 1/3 of the systemic. If the PA pressure is less than 50% of the pulmonary pressure, we assume that it is less than vascular resistance is low. So for that reason, we never always calculate, even by echocardiography. Pulmonary vascular resistance can be calculated by echocardiography, but not routinely done. Isolated ASD class 2A asymptomatic, right and left enlargement, right, QPQS more than 1.5, PA pressure less than 50%, pulmonary vascular resistance less than 1/3 of the systemic resistance. If even the patient is asymptomatic, it is better to close. What is class 2A recommendation? It is better to close. There may be some benefit of to close even in asymptomatic patient. Impaired functional capacity, right and right ventricular RARV enlargement, QPQS more than 1.5:1. Systemic pressure is less than 50% of the systolic PA pressure is less than 50 systolic pressure. Pulmonary vascular is less than 1/3. Here, adult with primum ASD, sinus venous defect, or coronary sinus defect. If all four is positive, so it is better to, it is must recommended that therapeutic is surgery. For ASD isolated, this is the second type of ASD, surgery and device. But in case of if it is ASD primum, sinus venous defect, coronary sinus defect, if all three are present, it is class 1 for surgery. So class concomitant surgical procedure. Concomitant surgical procedure is being performed right and left ventricular enlargement. যদি সিগনিফিকেন্ট এএসডি থাকে, আদার কোনো ডিজিজের কারণে এএসডি ক্লোজ অপারেশন করা হচ্ছে, সেক্ষেত্রে এএসডি ক্লোজ করতে হবে। Indicator of surgery and device in ASD ASD guideline 2020. Surgery and device in ASD plus in 2020 guideline কি আসছে? Patient with significant shunt, no PS, non-invasive sign of pulmonary arterial elevation of PVR less than 1/3, no LV disease should be undergo ASD closure regardless of symptom. ASD closure should be done regardless of symptom. This is class 1 recommendation in new guideline. Symptom, it is whether it's symptomatic or asymptomatic. If it is significant ASD, no severe pulmonary hypertension. Device closure is the method of choice for second type of ASD closure when technically suitable. So second type of technically suitable, it is suitable. All ASD, regardless of size, patient with suspicion of paradoxical embolization, exclusion of other cause, should be considered for intervention. This is class 2A. Small ASD, not significant hemodynamically, QPQS not more than 1.5:1, but there is a suspicion of paradoxical embolization. This is also true for PFO. When stroke cause, all causes are excluded in young patient of stroke, and the PFO or small ASD is found. So this is a class 2A recommendation to close the ASD or PFO, even it is not significant hemodynamic. So hemodynamic significance, not severe pulmonary hypertension, pulmonary arterial hypertension, no LV disease, undergo ASD closure regardless of symptom. And that this is the new guideline. This is the new guideline recommendation. Management of atrial septum, RV volume overload, yes. Pulmonary arterial hypertension, PVR more than 3, whose unit, no. LV disease, no. Closure of ASD. LV disease, yes. Balloon testing, weight benefit ratio, risk of closure before decision. Because LV dysfunction, if we close the ASD, the pulmonary LV diastolic failure may predispose. So before closing the ASD, if there is LV disease, we should be very careful. Even in device closure in adult patient more than 50, we always look for the pulmonary, always look for the LV EDP before releasing the device. We are putting the device in position, and then we measure the LV EDP. If it is rising, we'll give the diuretics. If the patient tolerate and the LV EDP decrease, then we release the device. Because LV dysfunction may precipitate it if we close the ASD, because some of the LV elevated LA pressure is transmitted across the ASD to the RA for in diastolic or systolic diastolic dysfunction of the. So if there is a diastolic dysfunction grade 3, grade 2 or grade 3 in case of ASD patient, that means that there is a raised LVDP. Raised LVDP means the LA pressure is raised. So LA, some pressure is relieved by ASD to the RA. So this may give some partial benefit. So if we close the ASD, there means a precipitation of a heart failure. So it is very careful. We should be very careful of LVD. What happens if the PVR is more than 3 Woods unit? If it is less than 5 or more than 5? If it is less than 5 Woods unit and QPQ is more than 1.5, yes, that closer. And if it is no, PVR is falls below 5 after PAH treatment and QPQS ratio still 1.5:1. If it PVR decrease less than 5, then fenestrated closure of ASD. Fenestrated closure. If PVR net not less than 5, it should not be closed. So here, if it is PVR less than 3, immediate close. No need of other tests. If it is less than 5, we can be closed immediately. But if it is more than 5, we should give the vasodilator drugs for decreasing the PVR less than 5. If it becomes less than 5 and the QPQ is more than 1, fenestrated closure of ASD, we can do the fenestrated closure of device closure, fenestrated surgical closure. Fenestrated device closure, we can make it customized. We can order. Sometimes it is company may make this fenestrated device in our need, or we can do a hole in the ASD device, we can put it. But it is experimental, not yet. And the surgeon, what the surgeon do? There is a small defect remains in the ASD with a fenestrated flap. So in ESC guideline, PVR less than 3, if it is less than 5, it can be closed. But if it is more than 5, we should wait with vasodilator. Here, if it is become less than 5, we should close. But if PVR remain persist more than 5, you should not be closed.
স্যার আমার একটা কোশ্চেন ছিল স্যার।
এখনো আমার ডিভাইস ক্লোজার বাকি, 1 ঘন্টা হয়ে গেছে, বেশি লেকচার নিলে তো আসলে হয় না। নেক্সট আমরা ডিভাইস ক্লোজার, হ্যাঁ কার তো কোশ্চেন ছিল, আর ডিভাইস ক্লোজার থেকে আসে নেবেন আরেকটা। আমার মনে হয় নেক্সট কোর্সে আমাকে আরেকটা লেকচার দেন, আমি এটা আর শুরুতেই দেন, তাহলে আমরা কন্টিনিউশনটা করে রাখবো। ফার্স্ট উইকে আপনারা যারা আমার রেজিস্টার দেখে একটু বলেন যে স্যার বলছে যে শুরু ফার্স্ট সপ্তাহে বা সেকেন্ড সপ্তাহে, আর ফার্স্ট সপ্তাহে দেখ এই নেক্সট উইকে বা এই সপ্তাহের বুধবার দিন দিতে পারেন, মঙ্গল বুধবারে, তাহলে আমরা আরেকটা এটা কমপ্লিট করতে পারবো। এবং আমরা যখন ডিভাইস লাগাই তখন যদি একটু প্রেজেন্ট থাকেন তাহলে আরো ইজি হয়ে যাবে, একদম ইজি হয়ে যাবে। আমার যেমন নেক্সট 29 তারিখে ডেট আছে, আমাদের ডেটটা দেখে নেবেন। 29 তারিখে আমার ডিভাইস ক্লোজার থাকার কথা 3-4টা, আপনারা যদি থাকেন তাহলে অবশ্যই দেখতে পাবেন। এবং প্রেজেন্ট থাকা মধ্যে প্র্যাকটিক্যালি দেখা এবং থিওরি বোঝা অনেক কঠিন। তো আমার মনে হয় যে এসডি ডিভাইস আজকে না বলি, আমরা নেক্সট লেকচারে বলবো। ঠিক আছে, কি কোশ্চেন ছিল এবার বলেন।
স্যার যদি আমি ইকোতে দেখি আরএফ ভলিউম ওভারলোডের কোনো ফিচার নাই, তাহলে কি স্যার হচ্ছে আমাদের কার্ডিয়াক ক্যাথ করার দরকার আছে যে আমার কিউপিকিউএস টা দেখার জন্য?
QPQS can be calculated in echocardiography and accurately, so it is not need to do the cardiac cath for QPQS ratio. But in a borderline cases, whether it is QPQS is significant or not, then we can go for cardiac catheterization. In a small ASD, when there is no RARV enlargement, it is evident that it is that the QPQS ratio is not elevated, but by echocardiography we can calculate the QPQS.
আর আরেকটা স্যার ইএসসি গাইডলাইনে কি স্যার হচ্ছে ভেসোডাইলেটর টেস্টের কথা লেখা নাই, আমরা কি যদি পিভিআর যদি স্যার বেশি হয় তাহলে কি স্যার ভেসোডাইলেটর টেস্ট করবো স্যার
আগের
এখানে?
টেস্ট আগের গাইডলাইনটা ওটা কিন্তু বুকে আছে, যে আমরা যেটা প্রথমটা দেখালাম সেটা কিন্তু মোশন অ্যাডামসে আছে। ফলে ওইটাকে আপনারা ধরতে পারবেন, কোনো অসুবিধা নেই। ওই গাইডলাইন ফলো করলেও যে কিছু হবে না। ওখানে আছে হলো কি হলো, এটা হলো 6 to 8 border line, more than 8, তো 6 to 8 অথবা মোর দেন 8 হলে ভেসোডাইলেটর টেস্ট করে যদি পজিটিভ পাওয়া যায় তাহলে করে দিতে বলছে। ওইটা ফলো করলে যে খুব কিছু হবে তা না। তো কারেন্ট গাইডলাইনে ভেসোডাইলেটর টেস্টিংটা রাখে। আগেরটা ফলো করলে কেউ আপনাকে ভুল বলবে না। তাহলে এ পর্যন্ত আর কোনো কোশ্চেন আছে কারো? তাহলে আমরা আজকে শেষ করি, কারণ হলো নাকি আজকে বলে দিব? আমার মনে হয় আজকে শেষ করি, কারণ হলো যে একদিনে এত বেশি বললে হবে না। তাহলে 1 নাম্বার হলো এই পর্যন্ত আমরা যা জেনেছি যে এএসডি সিমটম নাই, তাতে কোনো সমস্যা নাই। যদি এটা হেমোডাইনামিক্যালি সিগনিফিক্যান্ট হয়, পালমোনারি ভাস্কুলার রেজিস্ট্যান্স লেস দেন 3 হয়, মানে আমরা যদি ক্যালকুলেট করতে পারি অথবা ধরে নিতে পারি যে পালমোনারি ভাস্কুলার রেজিস্ট্যান্স বেশি হয় না, এএসডি ক্লোজ করে দিতে হবে রিগার্ডলেস অফ সিমটম। ক্লাস 1 এটা হলো ইএসসি গাইডলাইন কারেন্ট। Device closure is preferable over surgery in second-term cases in suitable. এটাও ক্লাস 1 রিকমেন্ডেশন। ASD আপনাকে জিজ্ঞেস করবে ASD এরাল পেশেন্টের বেনিফিট কি, আপনি যে ক্লোজ করবেন কি বেনিফিট আছে? Sir, after the age of 40 there is increased 6% mortality of every year in an ASD untreated patient. So there is increased chance of mortality and there is increased chance of morbidity. What is the morbidity? The atrial arrhythmia, increased chance of atrial arrhythmia, and the rare chance of paradoxical embolism. So these are the 3 benefits of ASD closure of any age. At the age of 72 years, a suspected case of a paradoxical embolization, I have closed the ASD of 32 millimeter with a 38 millimeter. So this is required. This is necessary. So RARV dilated, pulmonary pressure is not raised. ASD should be closed in every patient.
স্যার আমার আরেকটা কোশ্চেন ছিল স্যার। স্যার আমরা ইকোতে পিএসপি কত হইলে এটা আমরা ধরে নিব যে এটা মানে মোটামুটি রেঞ্জের মধ্যে আছে, এটা কার্ডিয়াক
সিস্টোলিক প্রেসারের 2/3 এর বেশি হলে আমরা সাধারণত হাত দিই। সিস্টোলিক প্রেসার যেটা যদি থাকে 110, তার 2/3 এর বেশি যদি থাকে তাহলে হাত দেওয়া উচিত না। ইউজুয়ালি 60 ক্রস করে গেলে আমরা মনে করি যে কার্ডিয়াক ক্যাপ করে ডিসিশন নেব এটা আসলে করা।
পিএসপি 60 এর উপরে গেলে স্যার
আমরা সাধারণত তার উপর, এবং পিএসপি মেজারমেন্টের অনেকগুলো ফ্যালাসি আছে। আপনারা একদম অ্যাকুরেট ঠিক পাসটা নেবেন, কিছু কিছু মানে বিয়ার্ড পাস আছে, কিছু কিছু মানে বিয়ার্ড শ্যাডো, খুব পেইন শ্যাডো, ওগুলোকে এক্সক্লুড করে নেবেন। এবং আমরা রুটিনলি সাধারণত পিএসপিটা চেক করি, যাদের বেশি থাকে তাদেরকে দেখা যায় যে আমরা যা ইকোকার্ডিওগ্রাফিতে মেজার করি আর এমনিতে ইভেন কার্ডিয়াক কেট না করেও পিএ প্রেসার যদি আমরা সরাসরি চেক করি তখন দেখা যায় যে আসলে পিএ প্রেসার অত না, 50 নিচে পাওয়া যায়। আমরা যেগুলো 60, 55, 56 এগুলো দেখি, সেগুলো দেখা যায় যে আমরা যদি কার্ডিয়াক কাজ করে পিএ প্রেসার সেগুলোতে 50 বেশি যায়, ফলে তখন আমরা পুরো কার্ডিয়াক কাজ প্রসিডিউরটা করি। তাহলে hemodynamically significant, ASD producing right to left shunt, RARV dilated, pulmonary pressure not severe বা moderate, not more than moderate, সেই পেশেন্টকে ক্লোজ regardless of symptom। এটা হলো class 1 recommendation ESD guideline 2020। ASD, if it is less than 8 mm, there is a chance of closure. If it may not close after 4 years. So if ASD persists after 4 years, it should be, it is usual that it should be permanent. It is not closed. So after 4 years, any ASD, so there is a less chance of closure.
স্যার আরেকটু বিয়ে করে স্যার, আরবি ইকোতে যদি ডাইলেটেড না হয় আমরা কি ধরে নিতে পারবো স্যার কিউপিকিএস নরমাল আছে বা
হতে পারে। আমরা তখন অবশ্যই কিউপিকেএস অ্যাসেস করতে হবে। আমরা অন্যদের ক্ষেত্রে কিন্তু কিউপিকেএস অ্যাসেস করি না, আরবি ডাইলেটেড মানে ধরে নেই যে আমরা। তবে আপনারা আরেকটা জিনিস খেয়াল করবেন, যখন আমরা কখন মনে করি, আমি যেমন 2-3টা পেশেন্ট কনকমিট, একটা পেশেন্টের সিমিটার সিনড্রোম সেটা ডায়াগনোসিস করেছি, সেটা কিন্তু আমরা দেখছিলাম তার এএসডিটা মাত্র 12 মিলিমিটার, অনেক ডাইলেটেড, এবং দেখা যাচ্ছে যখন ডায়াগনোসিস করতে পারেনি সিমিটার, তখন আমি যখন ইনিশিয়াল ইকো করছিলাম আমার কাছে মনে হচ্ছিল এত ছোট এএসডি, পেশেন্টের বয়স 13, কেন তার এত প্রেশার বাড়বে? তার পিএসপি ছিল অ্যারাউন্ড 55। দেন আমরা ট্রান্সিসিপিজিয়াল করলাম, এবং ট্রান্সিসিপিজিয়াল ইকোতেও পার্মানেন্ট ভেইন গুলো তখন আমরা কিছুটা পেলাম, কয়েকটা পেলাম না। দেন সিটি করে আমরা ডায়াগনোসিস করলাম যেটা রিভার্সলি, তখন আমরা এক্সরেটা দেখলাম। এক্সরে দেখে আসলে ডায়াগনোসিস হয়নি, এটা আসলে রিভার্সলি আমরা এক্সরেটা চেক করেছি। রেট্রোগেট, রিভার্স না, রেট্রোগেট। আর কোনো কোশ্চেন আছে কারণ? তাহলে আমরা আজকে এখানে কুইজ করি।